Hi, and welcome to day 2 of this week's Crack the Case. This activity is jointly provided by National Jewish Health and Bonham CE. This program has been supported by an independent educational grant from Gilead Sciences. My name is Charlie Wray. I'm the hospitalist and internist at the San Francisco VA Medical Center and the University of California, San Francisco. Yesterday, I presented a case of a 67-year-old man with multiple comorbidities who was under surveillance in the observation unit after testing positive for COVID-19. His oxygen requirements increased steadily over 24 hours, from initially being 1 to 2 liters, all the way up to 4 to 5 liters, at which time he was finally admitted into the medical floor. Now that he's admitted, what's next for managing this patient? What therapeutics should you consider? Let's go over these. So our patient's obviously on oxygen, so that automatically makes him a candidate for remdesivir. In this case, he should probably receive a 5-day course of remdesivir. The next question we have to ask ourselves is, does this patient require dexamethasone, a corticosteroid? The consideration for adding dexamethasone is much higher in this patient because of his rapidly increasing oxygen needs, particularly given the precariousness of his respiratory status and his underlying comorbid conditions. As you may recall, NIH guidelines currently specify that dexamethasone should be started when O2 requirements are rapidly increasing. But we also have to consider the risks in using dexamethasone in this patient. As we all may know, this places the patient at higher risk for other potential infections, both in the short term and potentially in the long term. Could this also worsen his blood sugars? And it most likely could, but oftentimes those are risks we have to take in these patients. What type of supportive care does this patient require? I would argue that there are 4 or 5 things that we should consider. First, let's think about analgesics. We'd like our patients to be comfortable while in the hospital, so I think starting Tylenol or ibuprofen is very appropriate in this patient. Second, let's think about IV fluids. They're also likely helpful if a patient has an underlying infection. They can make the patient feel more comfortable and support their vital signs as well. Third, we oftentimes think about pronation in our patients with COVID-19. But because our patient's oxygen requirements were on the lower side and the patient wasn't requiring high-flow nasal cannula or BiPAP, pronation is probably not in the cards for this patient at this point in time. Next, we have to think about anticoagulation therapy in all of our COVID-19 patients. As many of us know, COVID-19 produces a prothrombotic state, which increases the chances of having blood clots. So in all of our COVID patients who are hospitalized, we need to get them on anticoagulation. Let's think about supportive care now that he's on the dexamethasone. Dexamethasone has several deleterious aspects to it that I think we can oftentimes control. A few things that I like to do. First, consider starting an insulin sliding scale on this patient. This will help keep his blood sugars in check while he's on the dexamethasone. Also, I like to provide a mild sleep aid, such as melatonin, to help my patients sleep a bit better in the hospital and counter those effects of the dexamethasone as well. And finally, if the patient's ever had a history of an ulcer or an upper GI bleed, I might also consider starting a PPI on this gentleman to, again, counter those negative effects of the dexamethasone. Now let's explore the clinical course of this patient. Given all the things we've done, we start to see that over the next 2 to 3 days, his oxygen requirements stabilize and start to decrease. Soon, you're actually able to pull him off oxygen completely. His symptoms improve with the remdesivir and the dexamethasone, and he was well enough to discontinue both of these medications by day 5, and we were able to discharge him home. Let's review 3 key takeaway points from this case. First, patients with moderate COVID disease and minimal oxygen requirements should be started on remdesivir. Second point, if those oxygen requirements start increasing, as they did in this case, get the dexamethasone on board, as there's good data to suggest a mortality benefit using corticosteroids in these patients. And third, feel free to stop both remdesivir and dexamethasone at discharge, as there's no need and no associated benefit to continue them past hospitalization. Thank you so much for joining us. Please complete the post polls and the tweets below, and make sure to claim your CME credit. Click like and follow for more social media CME.